Good afternoon, everyone. Please let me know if you can hear me and you can see my screen so that we can go ahead and start. Hello?
Hello.
Yes.
Okay, thank you very much. Okay, thank you very much. Thank you.
Good afternoon.
Good afternoon. Good afternoon, everyone. Thank you so much for spending us time from your precious Saturday to join us for yet another edition of the Founder Series. So today we are in lecture 18 of the Founder Series anchored by the Kunle Hassan I Foundation Academy. And we'll be looking at the topic Sustaining Success Across Generations, Strategic Partnership for Expanded Reach and Impact in Healthcare. So right now I'm doing the welcome address. My name is Frances. I work with the Kunle Hassan I Foundation Academy. And this is the program for today. We're having the welcome address now, followed by the introduction of the speaker. Then we'll listen to the presentation from our speaker. We'll have our interactive session and the closing remarks. Just a few house rules before I introduce the Kunle Hassan I Foundation Academy. This lecture is being recorded. So we plead with everyone to please have their microphones muted, their cameras turned off. Only the speaker, when he's presenting, will have his camera up and his microphone unmuted. After the lecture series, the presentation, there'll be a session for interactive questions. So at that time, if you want to speak, you can either raise your hand up and you'll be called upon, or you can type your questions in the chat box and it will be read out. I welcome you once again to our Founder Series. It is a series organized by the Kunle Hassan I Foundation Academy. This is lecture 18. It started in 2020. We've had several things over the years. And the Kunle Hassan I Foundation Academy is a part of the I Foundation Eye Care System. The I Foundation Hospital is a part of that I Foundation Eye Care System, and it was established in 1993 with a vision to eliminate avoidable blindness through the provision of equitable, qualitative, quantitative, and affordable eye care to all. The I Foundation Community Hospital was established in 2006 as a social enterprise arm of the I Foundation Hospital Group to extend quality eye care to the poor, the vulnerable, and the less privileged. The Kunle Hassan I Foundation Academy, which was formerly known as Deseret Community Vision Institute, oversees the training of ophthalmology residents, fellows, middle-level ophthalmic practitioners, optometrists, and ophthalmic nurses. What the Kunle Hassan I Foundation Academy is trying to do is to bridge the gap in the depth of human resources in terms of eye health care. A part of the arm is also the Eye Shop, the Summit Vision, and the Summit Healthcare Pharmaceutical. So we've had 17 lectures in the past, some of which are all displayed on the screen. The topic, you can go to our Kunle Hassan I Foundation Academy YouTube page to watch the previous sessions in the series. So I'll move quickly now to introduce our speaker today. Our speaker today is Pastor Kayode Peter. He is a seasoned financial expert and transformational leader with over 30 years of experience in banking, capital markets, and development finance. As the Managing Director and CEO of the Bank of Industry from 2017 to 2023, he steered the institution through one of its most dynamic growth periods, expanding its balance sheet from over 700 billion to over 3 trillion and raising over 5 billion in international funding. Under his visionary leadership, the Bank of Industry delivered a landmark of over 700 million euro bond, supported critical sectors like the agro-processing, the renewable energy, the information communication technology, and enable large-scale industrial transformation across Nigeria. Pastor Peter began his illustrious banking career in the year 1986 at Citibank, Nigeria, and he has held executive and CEO roles at FSB International Bank, Unity Bank, and First Interstate Bank. He is widely regarded for his pioneering work in major financial transactions, mergers, and institutional restructuring, making him one of the most respected voices in corporate finance. He holds a Bachelor of Science degree in economics from the University of Ibadan, where he was a UAC scholar, and he has a Master's in International Management from the Thunderbird School of Global Management in Arizona as a Rotary International Scholar. He's also an alumnus of the Lagos Business School, the London Business School, and the Hagar Institute in Singapore. Beyond boardrooms and bond markets, Pastor Peter is a man of deep faith. He serves as a senior pastor in the Redeemed Christian Church of God, Nigeria, currently pastoring the City of David and leading the Favored Family. He has also served as the chairman of the Board of Trustees of Redeemer University and continues to champion causes that uplift the vulnerable through initiatives like Habitation of Hope. His many recognitions include African Banker of the Year in 2019 and the Special African Banking Leadership Award in 2023. Please join me in welcoming a visionary, a nation builder, a pastor, and an inspiring leader, Pastor Olukayode Peter. Thank you very much.
Thank you very much. Good afternoon to everyone. I want to thank you for the invitation to be the guest speaker today on the 18th lecture of the Founder Series. I believe that we will have some time to discuss after the paper. So I'll be talking this morning on the sub-theme of from synergy to legacy. Building.
Sorry, sir. Please, can you share your screen, please?
Okay.
Thank you, sir.
Can you see the screen now?
Not yet, sir.
We can see it.
Yeah, I can see it.
I can see it.
Okay, it's up now, sir.
Okay. So I'll be speaking on the sub-theme from synergy to legacy, building enduring healthcare institutions through cross-sector collaboration in Nigeria. Introduction. In the evolving landscape of healthcare development, the emphasis has shifted from isolated intervention to synergistic collaborations that build sustainable and resilient systems. In the context of Nigeria, where healthcare challenges span infrastructure deficits, workforce shortages, and funding constraints, the concept of synergy, the cooperative interaction of multiple sectors, has emerged as a potent strategy. When effectively harnessed, such synergy does not merely address immediate health needs, but fosters a legacy. Institutions capable of enduring, adapting, and leading in healthcare delivery over time. This seminar paper explores how Nigeria can move from ephemeral partnerships to enduring healthcare legacies through purposeful cross-border collaboration. It situates this analysis in recent healthcare policy initiatives, public-private partnerships, PPPs, digital innovations, and community-driven models. Through case studies and critical reflection, it highlights how Nigeria can transition from fragmented health responses to a coordinated and resilient institutional framework capable of addressing the country's healthcare needs sustainably. Policy and strategic frameworks enabling collaboration. In recent years, the Nigerian government has demonstrated a deliberate policy shift towards institutionalizing cross-sector collaboration as a central mechanism for strengthening its healthcare system. Building on the Foundation Health Sector Renewal Investment Initiative, NHSR2, launched in October 2024, the government aims to restructure healthcare delivery by forging robust partnerships among federal and state governments, private investors, and international partners. The NHSR2 outlines a commitment to achieving universal health coverage, UHC, through a coordinated sector-wide approach, SWAP, emphasizing the realization of donor and domestic investments under a unified national health plan. As part of this initiative, the government is also working with state health ministries to revamp primary healthcare centers, leverage digital health tools, and expand health insurance enrollment under the National Health Insurance Authority, NHIA, Act of 2022. Complementing the NSHR2 is the Health Sector Strategic Blueprint 2024 to 2027, which prioritizes governance reforms, health security, and resilient infrastructure. It calls for enhanced public-private partnerships as a core strategy for mobilizing non-monetary financing and technical expertise. This is particularly relevant in the context of Nigeria's fiscal limitations, which have constrained public sector investment in healthcare. The blueprint identifies key sectors: diagnostics, pharmaceutical manufacturing, hospital infrastructure, and health technology as prime areas for cross-sector engagement. By creating an enabling environment for private sector participation, the document seeks to transition Nigeria's healthcare system from a donor-dependent model to one that is sustainable, inclusive, and locally driven. Another significant initiative launched in 2023 is the Presidential Initiative for Unlocking the Healthcare Value Chain, PVAC. This program was established to address the chronic underdevelopment of Nigeria's healthcare manufacturing ecosystem. Through PVAC, the government signed strategic memoranda of understanding with international organizations, including the U.S. Pharmaceutical Convention, USP, to enhance local production capabilities and quality assurance. The initiative goal to meet 7 of the nation's particular needs locally by 2030 is ambitious but critical, especially in the light of vulnerabilities exposed during the COVID-19 pandemic and the subsequent retreat of foreign aid. PVAC also promises to generate an estimated 30,000 jobs, thus align health policy with industrial and economic growth strategies. In parallel, the NHIA Act 2022, which repeals the National Health Insurance Scheme, NHIS Act, has provided a statutory basis for mandatory health insurance coverage for all Nigerians. This policy marks a paradigm shift in health financing aimed at improving risk pooling and reducing out-of-pocket spending. Specifically, the NHIA Act encourages collaborations between state health insurance agencies, HMOs, and private providers to extend coverage and service access.
Sir, please, we lost your slides, sir. We can't see your slides, please.
Okay, you can. Are the slides back on now?
Yes, it's back up now. We can see it. We can see your slides now, and your microphone is muted. Please unmute, sir.
Okay.
Thank you.
Can you hear me now?
Yes, we can.
So we're on slide 6, page 5, written policies. Is that what you have there? Okay.
Yes, sir.
Then go to the next page, which is the recent. That's page 6. Okay. Together, these policies and frameworks represent a coherent attempt by the Nigerian government to institutionalize cross-sector collaboration, not as an optional innovation, but as a core pillar of health system reform. By aligning health goals with industrial, educational, and economic policies, these strategies aim to convert synergy into long-term regional legacy, marking a significant step towards resilient, equitable, and enduring healthcare delivery in Nigeria. So next slide, we now go to case studies of cross-sector projects. Slide 7. Some of the case studies. Diagnostic manufacturing COVID biotest kit plant. In response to funding cut by US aid in 2023, Codex Bio, a private Nigerian company, partnered with a global diagnostic firm, FD Biosensor, and the World Health Organization, WHO, to establish local manufacturing plants in Lagos. The facility has a production capacity of approximately 147 million HIV and malaria diagnostic kits annually. This partnership not only filled a critical gap left by reduced donor funding, but also positioned Nigeria to export diagnostic kits regionally, thus enhancing national and continental healthcare self-sufficiency. The Codex Bio initiative is a landmark in health diagnostics as it transitions from donor dependency to domestic production, leveraging international quality standards and local manufacturing. This synergy between the private sector, global health bodies, and government regulatory agencies lays the foundation for a diagnostic legacy in West Africa. The next one, infrastructure PPP, Lagos Medipac Hospital. In December 2024, Lagos State Government commenced the development of the Lagos Medipac Hospital, a 140-bed multi-specialist health facility under a PPP model with a LASSO consortium. The Medipac is designed as a comprehensive health hub, integrating diagnostics, specialist treatment, training facilities, and even a retail center. This model demonstrates how integrated healthcare infrastructure can reduce medical tourism by providing high-quality services locally. Moreover, it contributes to workforce development and continuous medical education, ensuring the long-term viability of health institutions beyond the lifespan of political administrations. Next slide, slide 8. Community level PHC revamp. That's the Rebuild Lagos PHC. The Rebuild Lagos Trust Fund, established post-EndSARS, has successfully refurbished the Ga Idungoran Primary Healthcare Center through a CSR partnership with Zenith Bank. Completed in 2023, the facility now includes integrated laboratory services, telemedicine capabilities, and dedicated training spaces. This initiative exemplifies how community-based corporate-sponsored projects can revitalize the primary healthcare system. By embedding training and digital health into PHC services, this collaboration builds a model of community resilience that can be replicated across Nigeria. Government and private academic training. MOU at National Hospital Abuja. In March 2025, National Hospital Abuja entered into a partnership with several academic institutions, including Nile University, to improve clinical training and residency programs. This initiative addresses the gap in the healthcare workforce pipeline, elaborated by the immigration of skilled professionals, brain drain. Through joint curriculum development, practical residency placements, and academic exchange, this collaboration not only builds capacity, but ensures that institutional knowledge is retained and improved across generations. It underscores the role of academia in sustaining healthcare legacies through structured talent development. Next slide. National Expertise Integration, Nigeria, Israel in Abuja, FMC. In February 2025, Nigeria and Israel launched a bilateral project focused on advanced gastrointestinal care at the Federal Medical Center in Abuja. The partnership included infrastructure development, staff training, and knowledge transfer in liver and pancreatic surgery. Such high-level collaborations bring global best practices into Nigerian institutions, establishing centers of excellence that can train local specialists. The lasting value lies in knowledge retention and infrastructure continuity, turning short-term cooperation into long-term institutional legacies. Digital health innovation, Advisor AI for vaccination. The deployment of Advisor AI for data-driven vaccination strategy in Oyo State, developed through a partnership between government bodies, NGO, and research institutions, reached approximately 13,000 families. The tool uses artificial intelligence to optimize vaccination outreach based on demographic and geographic data. By embedding digital innovation into public health planning, Nigeria is demonstrating the value of data-driven cross-sector solutions. The scalability of this model holds promise for long-term public health surveillance and national strategy. Infrastructure resilience, EU-funded solar health in Plateau State. In February 2025, a 1.7 million euros European Union project in partnership with GIZ and the Plateau State government installed solar energy solutions in 25 rural healthcare facilities. The initiative ensures uninterrupted power for essential services and refrigeration of medical supplies. This example showcases environmental health strategy synergy, improving the reliability and sustainability of healthcare delivery in underserved areas. By reducing dependence on erratic grid power, these facilities are better equipped to function as resilient service hubs. Next slide. What are the drivers and success factors? Several key factors underpin the effectiveness of cross-sector collaboration in fostering sustainable and resilient healthcare institutions in Nigeria. These factors function interdependently to strengthen general frameworks, optimize resource use, and embed long-term sustainability into health sector interventions. Foremost among this is the presence of strong policy and legislative backing. Initiatives such as the Presidential Initiative for Unlocking the Healthcare Value Chain, PVAC, and the Health Sector Renewal Investment Initiative, NHSR2, are not ad hoc programs, but are embedded within broader national policy frameworks and strategic documents. Their formulation and implementation have been guided by national health planning instruments, such as the Health Sector Strategic Blueprint 2024-2027, and are aligned with statutory mandates like National Health Insurance Authority, NHAI, Act of 2022. This institutional grounding ensures continuity across political transitions and enhances the likelihood of long-term success and impact. Equally significant is the role of resource pooling and shared risk. Cross-sector collaboration enables the combination of financial capital, technical expertise, infrastructure, and human resources from multiple stakeholders, including government, private investors, development partners, and civil society. This collaborative financing model enhances the viability of large-scale and capital-intensive projects. For example, both the Lagos Medipac Hospital project and the Codex Bio Diagnostic Manufacturing Facility are illustrative of how shared investments can accelerate material growth, improve access to quality services, and reduce dependency on volatile donor aid. Local ownership and community engagement also emerge as critical components of sustainability. Projects that incorporate the participation of local communities, national institutions, and grassroots organizations tend to be more responsive to local health needs and are more likely to be maintained over time. The refurbishment of the Igon Idungoran Primary Healthcare Center in Lagos through a public-private partnership involving the Lagos State Government and Zenith Bank. It's an instructive case. It demonstrates how community center design, stakeholder engagement, and CSR-driven investment can revitalize primary healthcare and promote user confidence. Another pillar of effective collaboration is workforce development, particularly through academic and clinical partnerships. The persistent shortage of skilled healthcare professionals in Nigeria, exacerbated by migration and insufficient training infrastructure, necessitates strategic interventions. Regional collaboration such as the Memorandum of Understanding between National Hospital Abuja and Nile University aim to bridge the gap in human resources for health. These initiatives provide clinical training opportunities, expand residency placements, and promote knowledge exchange, thereby ensuring that institutions are not only served by, but are also sites of continuous learning and innovation. The integration of digital health technologies further strengthens the collaborative ecosystem. The Advisor Initiative, which uses AI to optimize vaccination outreach, exemplifies how digital tools can enhance efficiency, expand coverage, and support data-driven public health planning. Such technological innovations, when implemented through partnerships involving government, NGOs, and academia, can create replicable models that improve outcomes and build enduring systems for health surveillance and service delivery. Finally, international partnerships and knowledge transfer serve as catalysts for regional growth and global standard service delivery. Collaborative projects with foreign governments and organizations such as the Nigerian Israel Initiative, Advanced Gastrointestinal Care for EU-supported solar health facilities in Plateau State, bring essential technical expertise, training opportunities, and infrastructure support. These engagements help bridge expertise gaps, introduce innovations, and empower local actors to sustain and scale impact independently. Gaps and challenges. Next slide. After the case studies, we have the case studies. Next case study, we have gone through that. Next case study, written. And then you go to success drivers, which we have just finished. Move the slides forward. Success drivers, and okay, until you get to gaps and challenges. After success drivers and factors. Okay. That's slide 11. Gaps and challenges. Despite the growing momentum of cross-sector collaboration in Nigeria's healthcare system, several structural and operational challenges continue to hinder the full realization of its transformative potential. These challenges reflect both systemic constraints and governance-related bottlenecks that must be addressed to achieve sustainable health outcomes. One of the most persistent barriers is the complexity of coordination among the diverse sectors involved in cross-sector health initiatives. Effective collaboration typically involves multiple stakeholders, including federal and state government agencies, private firms, donor organizations, academic institutions, and civil society. However, in the absence of a unified arrangement in particular, coordination framework, efforts are often fragmented. Public-private partnership, PPP, arrangements in particular frequently suffer from misalignment of priorities, weak interagency communication, and lack of central oversight. This fragmentation undermines the coherence of harmonized governance structure. Duplication of efforts and inefficient resource allocation becomes inevitable. Another significant constraint is the limitation of financing mechanism. While domestic initiatives such as the Presidential Initiative for Unlocking the Healthcare Value Chain, PVAC, are aimed at encouraging local investments, Nigeria's healthcare system remains heavily reliant on donor funding. The recent scaling back of financial assistance from key global partners, such as USAID, has exposed critical vulnerabilities in the country's health financing architecture. This reduction in donor inflows has led to funding gaps in key areas such as immunization, maternal and child health, and HIV/AIDS program. Consequently, there's a pressing need to develop innovative domestic financing models, including sovereign health funds, diaspora bonds, and healthcare-focused impact investments to sustain ongoing reforms. Next slide. In parallel, challenges in regulatory oversight pose risk to the quality and safety of healthcare delivery. Regulatory agencies, such as National Agency for Food and Drug Administration, NAFDAC, play a vital role in ensuring the efficacy of pharmaceuticals and medical devices. While the WHO pre-qualification of NAFDAC, Central Drug Control Laboratory, 2023 marked a major milestone, the capacity of such institutions to enforce quality standards at scale remains constrained by underfunding, limited technical infrastructure, and workforce shortages. As healthcare delivery increasingly incorporates local pharmaceutical production and medical technology innovation, the demand for a stronger regulatory framework becomes even more urgent. Furthermore, geographical disparities in healthcare investment continue to deepen inequities in access and outcomes. Major urban centers such as Lagos and Abuja have been the primary beneficiaries of PPP projects and donor interventions, resulting in relatively advanced healthcare infrastructure and service delivery in these locations. Conversely, states in the Northeast and Northwest regions, already burdened by conflict, displacement, and poverty, remain underserved. These spatial disparities not only exacerbate health inequalities, but also threaten the inclusiveness and national scalability of collaborative health initiatives. Lastly, the absence of comprehensive monitoring and evaluation systems limits the ability to track the performance and outcomes of cross-sector collaborations. Many initiatives operate without standardized indicators or real-time feedback mechanisms, impeding evidence-based decision-making. Without robust M&E frameworks, it becomes difficult to replicate successful models, identify gaps, and analyze lessons learned. This weakness also affects accountability and transparency, further diminishing public trust and stakeholder commitment. Combating challenges through policy reform, strengthening and capacity building is essential to ensure that collaborative health interventions transition from episodic success to enduring national impact. Next slide. What are the key lessons and recommendations? Next, after the gaps and challenges, we now have from synergy to legacy, lessons and recommendations. Okay. To ensure that collaboration translates into lasting healthcare institutions, several strategic recommendations are proposed. 1. Institutionalize PPP frameworks. Embed PPP models into state and federal health budgets and laws, as advocated by the Healthcare Federation of Nigeria. Embedding PPP models within legal and financial frameworks will provide continuity across political administrations and offer clarity on risk sharing, accountability, and value for money assessment. The Healthcare Federation of Nigeria has advocated for this transition to ensure that PPP evolve from associated agreements into formalized mechanisms for sustainable health system development. 2. Create integrated investment pipelines. Use initiatives like PVAC and Nigerian Sovereign Investment Authority to support infrastructure and pharmaceutical investment projects. 3, scale proven pilots. Projects such as Advisor AI, solar health infrastructure, and Medipack hospitals should be replicated across regions, especially in underserved areas. Scaling such interventions across underserved and remote areas can reduce regional disparities, optimize resource use, and accelerate progress towards universal health coverage. Next one, you can invest in workforce development, strengthen academic clinical linkages, introduce bonded scholarships, and incentivize diaspora engagement. Next one, ensure regulatory strength, expand the reach and capacity of NAFDAC and other agencies to uphold standards, particularly as domestic production increases. Expanding the capacity of regulatory institutions will safeguard public health, support international accreditation, and foster consumer trust in domestically produced goods and services. Mandate transparent impact reporting. Develop centralized platforms for data collection, evaluation, and public dissemination to foster accountability. Next, expand equity and coverage. Allocate special intervention funds to extend collaborative models to rural and conflict-prone regions. This includes the Northeast and Northwest regions, which have historically been under-resourced and disproportionately impacted by public health crisis. The targeting of these regions with infrastructure, personnel, and social protection programs can help bridge systemic disparities and promote inclusive national health development. Next slide, conclusion. Conclusion, Nigeria stands at a pivotal junction in its healthcare development trajectory. As donor support recedes and national priorities shift towards self-reliance, the imperative for cross-sector collaboration grows stronger. From Codex Bio's diagnosis factory to AI-driven immunization and solar-powered PhDs, recent examples illustrate that synergy among stakeholders can produce results that endure. To transition from synergy to legacy, however, Nigeria must institutionalize collaborative models, strengthen accountability, and prioritize local capacity development. Only then can it build health institutions that are not only functional today, but capable of adapting, innovating, and thriving in decades to come. The legacy of healthcare in Nigeria must be one of inclusion, resilience, and excellence, and that can only be achieved through coordinated strategic collaboration. Thank you. That is the part one of my talk. I'm sure at the end of the session, people that want a copy of the paper, they can be given, because it has a lot of things that some people might not be aware of. But I'm sure you are looking at what is practical, what can be done. I'm a doctor-friendly man because I'm married to one of you. My wife is a doctor. She's a specialist pediatrician. He trained at Luth. So because I've lived in the same house with her for over 35 years, I have an idea of what is happening in the medical area. Can you hear me?
Yes, we can hear you, sir.
So I will give you a few of the examples of the things that I've experienced personally and what I see we can do. Not only am I friendly to your, to your profession, we have when I served as the MD CEO of Bank of Industry, I ensured that the money of the bank was put to where my mouth is. For instance, under me, we took equity in the Center of Excellence Hospital in Abuja. Aside from African Export-Import Bank in Cairo, I think BOI might be second or the third largest shareholder in that hospital. NNPC at that time, they were still talking about it. We are putting our money, because for us, under me at BOI, it's not only about making a lot of profit. It's ensuring that we have things in Nigeria. We can curb medical tourism. and encourage our own. Investment in healthcare is long-term investment. Not only that, while I was MDC of Bank of Industry, we also took stake, equity in Iwosan, Lagoon Hospital in Lagos. They had a peculiar situation. IFC, some of their investors, they wanted to pull out. So how many people had the resources to buy? And then if you allow them to go, one of the very few hospitals that we have that is doing fairly well might go under. So we back them up and we put in equity also into that. So I'm familiar with your industry. Like I said, while I was MD, we actually invested in 2 of them. Before I left, we are concluding another hospital in Abuja, one of the biggest. Maybe now they've gotten the money, but that was before I left. We are also working on one in Abuja. So I know that funding for healthcare is difficult. If you're going to approach a commercial bank today to take money at between 25 and 30%, how can you make profit? Your equipment are very expensive. And most Nigerians, by the time you want to get this money back, they are not paying the type of charges that you need to charge to have your returns. I do my medical examination in Nigeria and most times overseas. I was one of the, well, I can mention, I was in Remington, their gold, you can call it gold class kind of exam. It's just slightly over £500,000. Then I go to London, we spend over £2,000. If you want to do other exams, it's going to cost you more, But I'm sure most people still prefer to go to London than be in Nigeria. Why? When they have hospitals in Nigeria that can do a similar thing. Looking at PHC, that also I know the problem in that area. I was a pastor in Ajah for about 14 years before I was transferred to my current parish in VI. In Ajah, we noticed that there were a section of people that were taken from Morocco. They could not really afford, to pay, in the hospitals around the area. So anytime the church will have a free program for medicals, the doctors that will come there, they will work from morning till night. So we began to think of what we can do. Somebody now told me there's a PHC around the church. So I went to go and see local government chairman. Truly, there was a PHC there, but it had never worked for one day. So I asked the local government chairman, why? He said there was no budget to run the place. So it's built, not too many facilities, but never worked for one day. He didn't have no doctor, no nurse, nothing at all. So I told him, can the church take over the PHC? He said, no, belongs to government. But we wanted to help the people. So we went back, and came back to them and said, okay, fine. We don't want to put our name there. We will leave it at local government ownership, but we will employ doctors there. We employ nurses there. We pay them every month. They now agreed. For the past maybe 3 or 4 years now, we have been more or less running that PHC, paying the doctors and the nurses to help the community. Because many PHCs in Nigeria today, in most states, they are locked up. They're not working. So I know in that area too, you have problems. Now you mentioned the issue of having Nigerian doctors who want to japa. Many of them have jackpot. I'm married to a doctor. My wife finished in Louth. She did a residency in Louth. When she finished residency in pediatrics, she went to University of Lagos, has a master's degree in public health. Then she came back and said, look, she wants to go to London to go and do a master's in mother and child health, University of London. We agreed. So when she had finished, I said to myself, finally, my wife has done all of these programs. We can now hand foreign exchange. She said, no. She wants to come back to Nigeria to work for Louth. I said, with all your training, with what we have spent, to make matters worse, my wife was born in London. She didn't have to fight to get documents. She has a UK passport. She wants to come back to work in Louth to help the people. So, well, that was her choice. So she came back to come and try and work in Louth. She applied to work in Louth as a lecturer. The first thing that surprised me was they asked her to apply with 50 copies of her CV. I said, I've never had it before. He said, no, when you apply to these universities to be a consultant or a doctor, maybe a senior lecturer, you have to use your own money to make photocopies, 50 copies. I'm not talking of now, over 20 years ago. That's what she did. She was employed to work in Luth with all her education. And then when she resumed, they told her to go and look around. If there's any office that is locked, they had no office for her. Maybe somebody has gone on sabbatical. She come and let them know so they can give her office. That's how you treat people that want to work for Nigeria. Well, it doesn't take too long for her to leave Luth and join Chevron, where she worked for 21 years. And I know she has many friends because they are friends too. Some went to Harvard. They are willing to work for the hospitals in Nigeria, but they are badly treated. It's not every Nigerian doctor that wants to work overseas, that wants to japa. She had the opportunity to japa. It was very easy for her. She didn't japa. But Nigeria, quote and unquote, happened to her. She had to leave Luth. What more can I say? Like I said, it's a pleasure talking to you this morning. Maybe I will let you do your questions, but I'm aware of these problems in the industry. It can be solved, if you have the right people in place. The knowledge helps. The fact that my wife was a doctor, some of my decisions, even when I was in management and MD of the bank, I had seen what had happened in that industry. It was easier for me to assist the way I could, but I think we can do more for the medical profession in Nigeria. But for those of you who have stayed in Nigeria, we want to thank you. God bless you all. And for your particular subsector, I'm also very thankful, Dr. Harriman and the others. It's very interesting. I knew Dr. Harriman for many years, but then what happened to me was very interesting. I went to London about 12 years ago on vacation with my wife. We were on Oxford Street, and they were advertising free glasses, So I just said to my wife, look, can I go in there and go and do a free eye test? So I walked into one of the shops, offering free eye test, and somebody came to check my eyes, and then the lady left for somebody else to come and look at it. That one left also, called their boss. Eventually, they told me what was happening. He said, look, you are very lucky. Your retina is about to be detached. You have to go to emergency now. From Oxford Street to Moorfield. From Moorfield to emergency to do laser surgery in a private hospital. And the prof that did it, McHugh, after he had finished, it was successful, said to me, I have a partner in Nigeria. I have somebody that I worked with me, Dr. Harriman. So you don't have to come back here for your checkup. There are people in Nigeria who can do it. That was a good recommendation. And I'm sure there are many of you who are making Nigeria proud. So once again, thank you for inviting me. I will take the questions now. God bless.
Wow, thank you very much, sir. Thank you, Pastor Kayode Piton, for this very insightful lecture. We appreciate your time. So the floor is open for questions. You can please raise your hand. I see Dr. Kunle Hassan, our founder's hand is up. So, sir, please, can you unmute your mic and ask your question?
I'd like to thank Pastor for that beautiful presentation. It was quite enlightening, and it's quite also very pleasing that you also have one of us as your wife. So you have first experience. I really admire the outlay of the lecture and identifying all the gaps. But one thing I've seen not being addressed is the compensation of the medical professionals across the team, from the doctor down to the least guy. I've not seen a data telling us what percentage of the budget voted for health goes to the human resources that drive those initiatives. And as long as that is not done, comparing it with other advanced countries where our guys are migrating to, we will not fill the gap. From our own experience in Eye Foundation, our strength is in human resources. But keeping that human resources, we have to run a financial model that will enable them to achieve their own goals, not to themselves alone, but also the family. The children of doctors want to go to the best school. They may not be money bags or ride the most beautiful cars, but at least they want to be relevant within the society. How are we looking at that? If all these projects, beautiful projects, will go nowhere, if we don't address that, however well-equipped a hospital is the skill that drives the business. And we can see some of these hospitals you mentioned and some process, they are importing such skills from abroad. And some of our guys who are coming from overseas, and working in a top hospital in the state capitals, they are being paid, highly paid. And they do it and they go back. Why is it that we cannot create a sustainable compensation system that will enable them to stay and will enable also the doctors that have been trained to stay? I always like in this to a particular case. I've been in the banking industry for a while as a non-executive director, and I know when we headhunt for the best young HEDs, they are given targets. They are well compensated. They are provided all the paraphernalia of office to drive them, and they drive the job. But the doctors, you build the best hospital, you spend a lot of money, you bring in people to train people, we are not paying them. Then it will fail. The same thing, I was in Saudi Arabia for years as a senior consultant. Even as a senior consultant and head of department for UK, and I was well paid ahead of the others. Do you know my resident, who's a Saudi that I was training, was earning more than I was earning? Their government cherishes them and wants to keep them on the job. And when they see those who are training them, my resident was earning 3 times what I was earning. And when I was very happy with what I was earning compared to what I was earning in UK as a consultant. So we have to look at that compensation model and how we can invest in them. Once we can get that right, then I'm sure our health system will work. All those northeast and areas that are underserved, all the primary health care you are supporting, for the doctor to work in that place, I'm sure you'll be paying them more than what the government will pay them. So I think there's the need to really sit down and look at the percentage of the fund that is going to human resources development and also compensation in relation to the whole budget. You will see that is very, very insignificant. If we can get that right, a lot of our guys will come back to this country. And a lot of, even the residents are no more ready. They are getting less and less application for residency. That's because they're all going out to, you talk about Moffitt Hospital. We have one guy in a hospital for 20 years, fantastic guy. He was a link with Moffitt. Do you know Moffitt poached this guy? And he's a nurse. He became a clinical manager. They offered him £5,000 a month. And the guy came to me. I said, look, I can't stop you. You've been very good. And we did what we can do for you. So this is where we think we should have a deeper insight into how can we compensate the healthcare professionals and create a system that will make our healthcare system sustainable and achieve the goal. Thank you very much, sir.
Thank you, Dr. Hassan. First of all, congratulations for what you have been able to build over the years. We need more Nigerians doing things like that. And for those of us who were privileged to be where I was, I know what doctors had gone through to build things like that. Aside from the hospitals we invested in equity, most of the hospitals in Lagos, the big ones, the equipment, very expensive ones, we financed it. What we have said is what should happen. I'll tell you a short story. I got married about 35 years ago. Before I got married, I was staying in Surulere. I had a guy from the church who used to come to my house to help me wash things and everything. So I would give him some little pocket money. So eventually, one day, he got a job as a dispatch rider in Zenith Bank. That was 35 years ago. Then he came to my house. I had gotten married then, to tell me that I came to tell you I won't be able to help you wash your clothes again. You know, I've just gotten a job as a dispatch rider in Zenith, and they'll be paying about maybe 2,000 or about 3,000 naira. Now, my wife, who was a doctor, a consultant, who was working in Luth at that time, you know, was earning less than this guy, who had just gotten a job as a dispatch rider. You know, we don't treat doctors well. The problem is part of it is built into our system. When I say in our system, for instance, now, when resident doctors go on strike, say, look, what we are paying us does not make any sense, you know, and government increases what they pay resident doctor. The following month, you know, pharmacists are going to go on strike. And then you will see the nurses and the other guys that do the work in the hospital go on strike. And then government is looking at it in totality of what they are paying other workers. So, but until you have a bold government who will say, look, we can't treat these guys like this. You know, we need to do something better. And for the medical profession, I was telling them, there was another forum where I was, and I said, look, you have to look at the way they do things overseas also. For instance, we have specialists, high-level specialists, like you said, working different parts of the world. What stops some major financiers in healthcare to come together and build a facility? You don't have to own a hospital. You know, people hire a room to do operation overseas. You know, they do the operation and they go away. You know, if you can have a place that has everything, you know, when you have a way that you can reduce cost and provide quality care for Nigerians, like I said, when I looked at what I was paying at Renington compared to what I was paying in London, it makes sense to do it in Nigeria. And that is where it's going to go. Now, if we lose nearly all our doctors, the way things are going, many of them have left the country, then what they are paying doctors will go up. You know, for many years, even when my wife was working in some of the top hospitals in Lagos, you know, they were paying doctors 35,000 per month. There was a year I said, look, Femi, that's my wife's name. Can I start paying you salary and you can just stay at home? Because 35,000, it doesn't make any sense. With the number of years that he has spent in school, you know, you do first degree, you do medicine, you go and do postgraduate. She has 3 master's degrees, public health, mother and maternal health. She has an MBA, and you are paying them nothing. But places like Chevron, eventually my wife left Luth to join Chevron, and you cannot compare. If you look at the scale that they start doctors in Chevron, what they pay them. Now, when people are beginning to die in Nigeria, automatically the market will adjust. But until the market adjusts to pay something reasonable to keep our people in Nigeria, people like yourself, we have to have centers of excellence like you have now, because you're doing a good job, you know. And then the people will come to that place, you know, when you pay them differently, you keep your own doctors. There's many doctors, they don't want to earn what they're earning in London, but they want to be able to, like you said, send their children to good schools in Nigeria and things like that. Some of them are comfortable. You know, if Luth had behaved a bit better, my wife would have stayed in that place. He was not making any returns based on our investment on our education, but she was willing to stay. And she has friends like that. I'm sure you have friends like that also, you know, who will stay in Nigeria because they're patriotic, they want to help, but we're not treating them right. So something has to be done. I hope the Minister of Finance, let me tell you the story of Abuja Center of Excellence. You know, the main brain behind it was also Oke Orama. Oke Orama is about to retire now, the president of Afrexim. What happened to him? He fell ill. He spent about 7 or 8 months in King's College London Hospital. So when that guy now came back, well, by God's grace and the expertise of doctors, that is alive. For myself, who nearly lost my eyes, and I have a doctor as a wife, you know, it was easy for us to come together and say, look, let us do something for Nigeria. And that's why you have that place there. A lot of millions of dollars have gone into it. But we had personal experiences. I think if more Nigerians at the top have more personal experiences, or we have a way to reach out to them, because this system must change. Otherwise, it will collapse.
Thank you very much, sir.
Hello. Good morning.
Morning, sir.
Yes, my name is Dr. Yemi Oladimeji. I'm an associate professor of medicine at Georgetown University, Washington, D.C., United States. I woke up just to join this conversation. We will need your help, and we thank you. We thank you, sir, for the lecture. We need a solution to our problem. The solution that we like you, if it's possible, sir, with due respect, to help us organize people like you, to help Nigeria. According to WHO, ratio of doctor to patient in Nigeria is 5,000 patients to one doctor. And doctors are still leaving the country. Recently, I came to Nigeria to open regenerative clinic in Ikeja to help people with erectile dysfunction and patients with infertility. My training is nephrology, internal medicine with subspecialty in nephrology. So the problem we are facing in the country, you've talked about it, we need solution to these 4 points. How to improve the compensation and benefits to medical doctor. For example, if you are just a councillor today or chairman of local government, you can buy medical doctor that spent years going to school. We need your help, sir. Number one, how to improve compensation and benefit to doctor, how to improve working condition, and then clear development path. We need government to support the doctors. That is why we voted to to appoint someone to represent us in our local government, state level, federal level. Someone like you, sir, with due respect, and people of the same level with you. The medical doctor need you to submit a proposal to the Senate to transform our profession in Nigeria. I came to Nigeria, I invested money. I shuttle between Nigeria and Lagos right now. Because many men at the age of 45, they got erectile dysfunction. And we're doing it at Georgetown University with PRP. So I'm doing it in Lagos right now. Many women, most of them, they started very early, seeing their period, released follicles at the age of 35, 36. They will become anovulation, which we are correcting right now. I started that in Nigeria as a give back. We have so many equipment in my location, but it's very challenging to get medical doctor to let them know what we know, to even get them to hire. I pay them very well based on dollar rate compared to Nigeria to keep people working for me. We need your help, sir. We need the help of people like you to transform what we make doctor to stay in the country. WHO said the ratio of medical doctor to patient in Nigeria is 5,000 patients to one. Our people will be dying. We need your help. And this, our group, will support you. I personally will support. We need to form a strong team to present something to the Senate so they can help the medical doctor. Thank you, sir, for your time.
Thank you, sir.
Thank you very much. I think we should take some of the questions that were in the chat box. We have someone's hand up, but please bear with me while we take some questions that have been in the chat box for some time. So we have Dr. Dupe Ademola Popola. She said, sustaining the beautiful initiative remains a major challenge. One recalls the great work done by Professor Ransom Kiru from PhD levels to the tertiary care. We lost most of the gains and not reinventing. What can we do to sustain our initiatives? That's the question, sir.
Sorry, let me hear the beginning of the question again, please.
Okay, sir. She said, sustaining the beautiful initiatives remains a major challenge.
Okay.
One recalls the great work done by Professor Kiru from the PhD levels to the tertiary care. We lost most of the gains and not reinventing. What can we do to sustain our initiatives?
Okay. Yeah, thank you. Like Prof was saying, everything, rises and falls on leadership. The type of people that we have that represent us, it's very, very important from local government all the way up. Because you have a prof like late Ransom Kuti, with all of these things in primary health care that he has done and everything. Another government comes, they stop it because they don't fully understand it, or somebody is not persuasive enough, to get those funding from them. And sometimes it's not even funding. It's just a matter of doing the right thing. Like the prof said, the doctors need to have a lobby group, a strong lobby group. And it might be the senior doctors who are going to get involved in this because the young ones are frustrated. You can't blame them. After spending so many years in training, they come out, they pay them 200,000 naira, 250,000 naira. What is that? 300,000 naira in some places, to lobby government. The problem of Nigeria and Nigerians. At a point, I think doctors were taken out of the national scale because their salaries have to be different. You now have medical scale, that needs to be done. But as soon as government is trying to get that one done, then nurses say that nurses equate themselves to doctors. Then lab technicians asking for the same thing. And once they do that, and the general workers group see the disparity in their own pay, they go on strike also. But doctors cannot be put on that same level, And the country is suffering, like I said, 5,000 doctors to one person. In some areas, it's even worse. You go to the northeast and northwest, they don't even want to stay, So the only way you can have good policies that stay, starts from type of leadership that we have. If you're going to have a minister of health, for instance, you have one there now. Pate is supposed to be one of the good ones from the US. I understand he was an award-winning doctor, but can he convince government to do otherwise? Because otherwise, our health system is going to break down. People are trying their best. They're buying this equipment and things like that. And then you also look at the economy itself. There are many people who want to go for cancer treatment and things like that. They cannot afford it because of the level of poverty in the country. So the problems are multi-dimensional, but they're not insurmountable. Now that we are saving money from petrol, from the subsidy, subsidy has ended. The idea of ending the subsidy is that the savings will go into the critical areas. Things like healthcare, salaries of doctors and things like that can easily be absorbed from the savings. But there needs to be a strong lobby from medical profession, to let government know, that it's not, maybe they look at number of doctors, how many are they? How many votes do they have? They don't have enough votes. So you can only make noise, you can't bite. But people are biting different ways. They are flying out and people are suffering. Well, I think they need to be more lobbying at the right quarters for doctors so we can keep the ones that we have.
Thank you very much, sir. Let's take a question from someone's hand that is up. Dr. Brigid Eric Itola. I'm assuming that's you, ma'am. Please, can you unmute your mic and ask your question, ma'am?
Yes, thank you. Can you hear me now? Good afternoon.
Yes, ma'am. Yes, ma'am.
Thank you very much, sir, for the beautiful lecture. It was quite insightful. My thoughts are, I was wondering, considering the PPP model, Nigeria is a very big country with our population in terms of the mass of people. I was just wondering, that PPP model, if government could expatiate more on it in terms of the National Health Insurance Scheme. Because I believe that if the insurance health scheme works effectively, this private-public partnership should work. But the insurance scheme we have as at now, I don't think is working in terms of the number of people being covered. And I think government should actually give it a good drive. If government supports it very well, where you have at least 70 to 80% coverage or even 90% coverage, we should be able to have a robust PPP partnership where funds from the insurance scheme will be channeled towards capacity building, resources that we need, infrastructure, pharmaceutical, and I think with that, we should have a very strong, sustainable model in our country. Because when you have all these big projects that are just focused to the tertiary centers or super tertiary structures, invariably, emphasis is not given to the grassroots, to the people at the local government level. But if we have a robust, strong PPP partnership where funds are channeled to every small unit, as you can think, the smallest unit that you can think of, I think we should have a sustainable health insurance, a sustainable system on ground. So in summary, my thoughts really are for us to have a robust and strengthened PPP system that should work. Thank you very much, sir.
Yes. Thank you, ma. I agree with you. In the hospitals now that have PPP, you know, you can see that some of the facilities are working better. You know, people have to pay for it because somebody else was the person that bought the X-ray machine or any of the big ones, you know, MRI machines, you know, because they know that they have to recover their money. You know, it works. Lagos State, I think even all the way to mortuary and things like that, you know, they have people running them. If they do that in more hospitals, I think, you know, it will be better. And like you have said, if the insurance scheme works, you know, it makes things better for everybody. ECO tried it to reduce the cost, to make it more people. I don't know how successful Lagos State has been on that one. The other scheme that you have, you know, is not working as well. If it was working as it was designed, you know, I think it will help a lot because people are insured, you know, then they can go to the facilities and the hospitals can earn more, you know. But even what some of them are charging or they're allowed to charge, you know, whatever it is not enough to cover a lot of cost. We need to know that health is expensive, you know. If you want to have good health and everything, in most places it can be subsidized by government, but even what we have is not even enough. It's not enough. The people who are working in Nigeria, people like yourself, probably are still in the country, you know, is a subsidy to the economy. You know, we need to do more. But like I said, Nigerians have this penchant, you know, they don't realize. Maybe because I'm married to a doctor, I know the amount of hours you put in for your exams, what you do, and I say, with all of this work that people are doing, all these exams, this is what they are paying you. No, they just look at doctors as if they are ordinary graduates. They are not. They are not. You know, that has to be communicated. And people have to imbibe it. It's not that you want something, nurses want it. Lab tech, people want it because a doctor wants it. He didn't have the same type of training. That's part of the problem that we have.
Thank you, sir. I'll take a question from the comments box before I call on those that their hands are up, please. So I have from Dr. Tinuke Adeyinka. She has 2 questions. Her first question is, how can the Nigerian government take more proactive steps to alleviate the growing burden of eye care in the country by prioritizing sustainable funding, investing in critical infrastructure, and strengthening human capital in eye health sector? And her second question is, what policies or partnerships are needed to ensuring long-term impact and equitable access to quality eye care services nationwide? Should I take the first question first, sir?
Yeah, which sector? Is it the eye sector she mentioned, the first question?
Yes, sir. Both questions are for eye sector, sir.
Okay. Well, like I said, I'm a beneficiary of what you do in your subspecialty, because without God and some of your professionals, possibly today, I will not be giving you a lecture because I will not be able to read. The government can do more. And to be honest, it doesn't cost much to actually do high tests and things like that. In fact, we as pastors, if I use up my other cap now, anytime we have a major program, we invest in buying free eyeglasses to give to the people. They come, they do tests and checks for them and things like that. It's all part of what your association can also push. There are some students in schools who cannot see the board. They don't even know that they have eye problem and things like that. Maybe you also need as a body, maybe to go to secondary schools and things like that to see how you can promote this so that people can begin to take their eyes more seriously. It's not only for the eye sector, for all the medical sector that we have. We say, what can government do? Like I said, government is saving money now from the subsidy that are stopped. One prof said, and I agree with him, if you look at how much WHO has said that the minimum a country should actually spend on healthcare, we are far below that. So if Nigeria increases the budget for healthcare, and it should, then they will have more resources to do all of these things. You are owing doctors, in some states, they are owing doctors money. The allocation to states have increased. Local government allocation has increased, so they should look at that area. But like I said, because doctors by your nature, you study more and things like that, you're not politicians. Nobody is really talking for you. I mean, the way they talk for other people. But you should have a strong lobby, a strong lobby at the presidential level, that this thing is very critical. We have lost nearly all our doctors and things like that. What can we do about it? How do we retain our doctors? We don't have to pay like they pay in London. But definitely what they are paying doctors today, compared to the training that they have, doesn't make any sense, which is why it's demand and supply. You don't pay them, they go somewhere else. The number of Nigerian doctors I understand they have in the UK, in America. In fact, if Nigerian doctors were to leave the UK today and America, their health system, it will feel it. So yes, there's a major problem in that area, and government needs to do more. And local governments, the PhD that you're talking about, I was saying once, why don't they allow young doctors, to actually run those places? Let them make proposals. Go to a state, and there are many states in Nigeria with PhDs that has not opened for one day. There are young doctors who are who don't have money to build infrastructure. Can you not have a system whereby some young people can come together and take over one and run it at a profit, rather than have it built, and it's lying fallow? So we have to think out of the box.
Okay, thank you very much. I'll take about 3 more questions. Our time is fast spent so that we can call it. I have Dr. Ajayi Obe. Your hand is up. Please, can you unmute your mic and speak? Thank you very much.
Good afternoon, Pastor Kyrie Vito. Thank you very, very much for the wonderful paper. Very insightful. And I actually had enjoyed the case studies that you brought up. I talk from a medical perspective and also from an insurance perspective. And I'll focus a lot on the private healthcare. I mean, I'm very focused on community healthcare, but when it comes to private healthcare, I'd like to talk about it. As of today, I sense that the private sector are driving us with innovation, but it's very difficult for them surviving, and sustainability is very important. I think when it comes to energy, it's a big problem for them. Human resources is another problem. Therefore, and also when it comes to pharmaceuticals and all that, the cost of operations is very high. I was at a meeting recently and we were talking about energy. And I said, energy is expensive. Why aren't we encouraging solarizing these institutions, these healthcare institutions? I know that some people have taken on solar, but I think it's important that I'm a very practical person, that we drive it. Can we get banks? I know BI did a lot, but actually, in necessary, we can actually get investment, do a PPP, and get most of these private hospitals to complete turnover. I mean, they can't do everything on solar, but majority drive up the costs. So if they have some savings, they can put that into the human resource, or they have some free money too. I just feel we need to get practical so that these hospitals will survive. We talk about hospitals springing up, but hospitals are folding up. Lots of them folding up as well. So I'm wondering if we can come together, people can come together. It's for the best. If someone has a heart attack today in Nigeria, you won't get on the plane. Nobody will get on the plane. They have to at least stabilize you before you can get out. So I think I just wonder if we can have those partnerships where we can deal with energy. And if there are other things, I mean, I know the whole thing about doctors, they're going. If you can't give them enough money, they'll go. So that's just my question.
Okay. Thank you very much, Dr. Ajayobi. I know her very well. You see, what you have said is, energy is one of the highest, costs that the hospital will have to deal with. Not only the hospital, virtually any kind of company in Nigeria today, because light is not, energy, the supply, even though they say there's the priority line, you have 20 hours, but you don't really have it. So it costs a lot of money. And you have to recover that particular cost, which makes services to be expensive and drives away people ordinary that have come, which is why the insurance is important, because somebody else is paying for it. When it comes to solar is a good idea because it can take care of some of the things. In fact, most of the European countries today actually have packages, to encourage people to actually go solar. So if there are people that want solar, like in Bank of Industry, we have facilities for solar. The rates are good and long term. So what is important is that people don't have the knowledge, that this is available here or there. But we need to have more Bank of Industry, because even Bank of Industry cannot fund everything, But yes, there are facilities for things like that, and there are special facilities that allow you to borrow long term. But another thing that doctors have to do, you have to work more, in collaboration. A doctor sets up a hospital here, and the other person, wants to set up another one down the road. You can come together to see what you can do. Like I said, you can have shared facilities. You can build a place. You're a surgeon. You pay for a day, do all your surgeries, and you go away. You're an eye doctor. You have a room for some time. So you don't have to bear all of that cost. You have to be creative in how you do things. And I think Nigerians, we don't collaborate that much. It's not a strength that most Nigerians have. But you people are professionals. You have to cultivate it. It's the way the world is going. What can you do? How can we work together? Doctors have to work together. That's your specialty. This is my specialty. Can we have a place? And then rather than you now saying, look, I'm a pediatrician, and then you now rather than collaborate, you now open another hospital down the road. That one has a pediatrician also. Nigeria needs doctors. Nigeria needs hospitals, but the location is very important. What you do, So there has to be more collaboration, in that medical sector.
Thank you very much, sir. We have 2 more questions before we wrap up the day. I have Professor Adeola Onokoya. Your hand is up, ma. Please go ahead and unmute your mic and ask your question.
Thank you very much. Thank you very much, my pastor, for the insightful talk. And you really opened our eyes. But what I want to say is, for the human capital, majority of doctors who are doing well in Nigeria today, particularly those of us who are in government establishments, actually have your feet somewhere else. So what I want to say is there a way? What can we do for government? You said we should have a lobby group and all that, for them to know that the remuneration, as Dr. Hassan put it, for doctors is peanuts. Those who are in Nigeria today is because they're doing something else elsewhere in all these big hospitals that we're talking about. At a hospital now, residents, once they finish, they are not interested in staying back to the consultants. They want to go and work elsewhere in private hospital where they know their worth, they are well paid. So how do we get government to prioritize health and prioritize, and have this, know that a doctor should be properly paid? A doctor in government hospital in Nigeria of today, I work in the hospital, work in the university, all the salary cannot even to pay the accommodation where one lives, not to talk of send children to school, fuel your car and all that. What can we do, sir? With your experience, how do we get the ears of the government? Like you rightly said, a local government chairman earns more than a professor of many years. How do we tackle that, sir? Thank you very much, sir.
Thank you, ma. I think most of the questions revolve around the same question that you're asking me. You see, I'm already a convert. Like I said, I live with one of you in the house, and I know what she had gone through to get to where she got to. And compared to, well, fortunately, Chevron was a different place than Luth, but she was willing to work in Luth. I think government also might have to be creative, because most of the states that we have in Nigeria today, their recurrent expenditure is so high. Everybody wants to have a state. So they have these states, they are not viable. To even pay salary is a problem. So when a profession is not asking for money, it's as if they want to add to our problem. Honestly, government has to look for that money because of the way things are. But they can do things like for doctors, for instance, they can probably allow doctors to work some hours a week privately, officially. So that way you're not hiding. You're a professor of surgery or whatever you are, your specialty. You can go somewhere else and earn some extra money. They cannot pay you. They should allow them to earn some extra money as an incentive to keep the ones that we have who are in Nigeria today. Because clearly, the first, like I said, the medical skill, is out of the thing. You have to have that, which they have. But then, are you paying enough? We're not paying enough. In fact, is government paying anybody enough? When you look at the minimum wage, where can that one take you? So you cannot isolate the problem the medical profession is having with the general problem of the country. But then, within that particular problem of the country that we're talking about financially, how we manage our resources, doctors have to be isolated. You see, that is, somebody has to push it, you know, and it must be pushed in such a way that they understand, you know, maybe the statistics that you're going to do, maybe advert in TV, and some of the people who have done well, you know, might have to fund it. It happens everywhere in the world. But government can know what is going on, you know. If you have series of things that you do, maybe you can have a TV program. You can do that over a period, maybe 1 or 2 months, so that everybody in Nigeria knows about it, you know. But then one day, God will answer that prayer. But definitely, doctors have to do something. But it's not your nature to fight, you know. You people just do your work. You go to school, you pass exams, you read again. You know, you are too busy. You know, all this scheming that they have to do in politics. Unfortunately, that's how the world rolls today. Minimum thing that you can do is to ensure that in your own area, please don't elect, show interest in who becomes local government chairman. And when it's time for elections, let us go and vote. Because if you have the wrong people who are leading us, local government chairman has certificates and is making all the money. And the person with a PhD for many years is getting peanuts. No, it's the wrong thing. You know, we've gotten everything upside down. You know, it's not right at all. It's not right at all. It's not. I sympathize with the doctor.
Okay, thank you, sir. So I'll just read the question from the chat box. This is from Mr. Dele Salami. He says, public health policy operators have not achieved significant outcomes on the much talked about reform initiatives. From your experience in a federal financial institution, what are the corporate governance mechanisms for ensuring accountability?
Well, I think knowledge is very important. For instance, in Lagos State, you know, maybe one of these lectures, you know, I was there. One of them heard me and then came and so I said, look, can you help us? You know, we want to train our doctors in Lagos State, some of the people that run hospitals. You know, we have a program in Lagos Business School, you know, on, you know, capacity development. And we funded it for 2 years when I was at BOI, about 25 doctors, you know. So the more they are exposed to these management things, the better. One of the things that most doctors don't do, which is why the hospitals run into trouble, is that they've had many hours of studying medicine, but they don't have any deep knowledge of finance and management. I encouraged my wife to go to Lagos Business School, you know, to do a course many years ago. On her own, years later, tried to do an MBA, you know, the same school where I had my own master's, you know. Many doctors need to be trained in that area. Many of them are running businesses. A hospital is a business. And if you are not trained to run it properly, you lose money, you know. And that is one thing that you know, and the people who have done well, you know, they can actually mentor the other people who are getting into the same industry. Dr. Hassan and the others can look for serious doctors who are coming up and help them. Now, people who are coming into your profession who are not even doctors. You know, I know the person that is the hospital in Lekki. What's the other one? What's it called? I think Evercare. Evercare and the other ones. The people who are buying up these hospitals today are not even doctors. They are finance people. I heard Dr. Hassan saying that he was in the bank at one time. Okay, maybe now he's at the non-executive director. You know, so you need finance. You know, if you don't have it, get the right people. So training is very important. You need, when you talk of corporate governance, if you have not been exposed to it, you know, how to do it, what you can do, what you cannot do, what are the current thoughts about it, then you don't know what to do. So doctors need education on finance and management, all of you. And don't run businesses without it. You need minimum, maybe at least a course titled Finance for Non-Finance Professionals.
Thank you very much, sir. So our last question for today, I think from Dr. Jovita. Thank you so much for the lecture. Please, how do you access equipment loan from Bank of Industry?
Okay. Now, you can access equipment loan from Bank of Industry. What the bank has done is that we have seen over the years that there are people who are not familiar with the processes of applying for a loan. So the bank on its own have now appointed consultants. And those consultants are all over the country. Every state has BOI certified consultants. If you go to our website, you can see the name and then you can pick anyone. We don't normally say, pick this one. And then that person will take you through the process of application, what you need to submit and everything. And the cost of that job, the bank pays it. So it's an incentive. It's how we are helping the country. So go to the website of BOI, look at the state where you are in, ask questions, and then pick one of the consultants. Or better still, there's a medical desk at BOI, depending on how much money you are asking for. There are three main categories of companies. We have the small sized enterprises, even though you are a hospital, they look at your turnover. And then medium-sized ones, the up to about 2 billion naira in turnover. And then the large ones, over 2 billion in turnover. Now, most of the loans, from BOI, to access the loan, you need to have a bank in between BOI and you. The bank gives a bank guarantee to BOI, and BOI disburses the money to the bank to give to you. Why does BOI want a bank guarantee? Because BOI is not a commercial bank. The day-to-day that you're going to do will be done between you and that commercial bank. Secondly, the money BOI is going to give to you is highly subsidized money. Until I left the bank 2 years ago, the interest rate that we are charging was 10%. Now, if you are paying 10% in an environment where interest between 20 and 30%, you are being subsidized. So it will be the first point of call for people that want loans, especially in the hospital area. If what you are asking for is about 100 million, 200 million, 300 million, that one, if you have facilities, you can use those ones as security for the loan. But if more than 500 million naira, definitely require a bank guarantee. If what you want is about 10 million naira, then that one you just need 2 personal guarantors who will now attach to the guarantee statement of net worth. So I would say your first point of call, go to BOI branch that is nearest to you. There's one in Ikeja, head office in Lagos. There's one in Lekki, and try to see any of the officers there and ask questions. And it's possible.
Wow, thank you so much, sir. Thank you very much for this very insightful lecture. We appreciate you for honoring our invitation from the Kunle Hassan Eye Foundation Academy. We would like to thank everyone who took out time to join us. This lecture series used to hold once every month, but due to our listeners' advice, it's now going to be happening once in 3 months. Our next session will hold maybe in October, November, and we'll be posting out the updates. I'd like to thank everyone for taking out the time for joining us, our founder, our special speaker, Pastor Kayode Piton, for taking out the time. We appreciate you. We appreciate everyone else as we bring this lecture to a close. Thank you so much, sir. Thank you, everyone.
Thank you very much.
Thank you.
Thank you very much, sir. Thank you very, very much.
Well, thank you, guys.